Good morning, Emily. Thank you. I want to thank everyone for joining us this morning for an update from the Division of Adult and Community-Based Services at the Michigan Department of Health and Human Services. We have Belinda Hawks here, who is the director, and then Lyndia has also joined us, and she is the manager of the Federal Compliance Section. Thank you, ladies, for being here, and I'll turn it over to Belinda.
Good morning, everyone. Belinda Hawks. I'm the division director, as Sherry indicated, of the Adult Home and Community-Based Services Division within our Specialty Behavioral Health Bureau with the MDHHS. And today we're going to just give you a few updates related to some initiatives and projects we're working on within our bureau and specifically within our division. Next slide, please. So I wanted to cover a few areas that I thought would be of interest to you in this group. And those areas are conflict-free access and planning, which is, as folks might be aware of, a federal rule that took effect in 2014. And there are various pieces of that rule that have been in transition since then. And this would be one of them. We're going to cover some policy changes that we are making related to a recent settlement agreement. We're going to give a plug for our developmental disabilities practice improvement team and hope that you can consider being a member of that team as we start to recruit additional members. I want to introduce our new IDD specialist and then talk briefly about some work we're doing in developing an IDD continuum of care. Next slide. So one of the things that you would have been potentially a part of, either through some listening sessions that we have provided in the past year and a half, or in some webinars or information we've shared broadly related to conflict-free access and planning. And I did present on that rule last year. So feel free to go back to that presentation as well to kind of ground you in what that rule is about. And really, more broadly, it is an opportunity for states to reflect on how to provide services to individuals without the overlay of any conflict of the relationships between the provider of those services and those who are assessing for eligibility for those services. So that really is at the heart of conflict-free. It's an opportunity for us to move the needle in assuring that you are receiving the services that you should be receiving, and that you have choice in who provides those services to you, and that there's no inherent conflict in the relationship between those making those decisions. And so what we did to embed this language and the strategy for what we're going to implement going forward to assure compliance around this rule was to include language in our 1915C waivers and in our 1915I state plan renewal last year. And that information was then reflected in those approved applications that was approved in December of 2024 and in January of 2025 this year, which allowed us to then move to the next step of what we would need to do to implement compliance related to that rule. So the things that we're doing right now to get ready for going live with implementation is really to kind of think through what it is we need to ensure, both from the PIHP and the CMHP and their provider network, in developing implementation, oversight, and monitoring processes. So that includes a toolkit, training, outreach materials, etc., that we'll be developing in order to assure that everyone understands what is expected, how we will be implementing going forward, and what the oversight and compliance will look like for the state and for those providers providing services, in order to assure we are compliant with what we have now approved in our federal waivers. You might ask when we might be starting that work, because it does, I'm sure, feel to you that there's been some starts and stops related to this work, and that's true. And what do we want to do is we want to make sure that what implementation expectations we have, that there's enough lead time for all those involved to assure that they have the proper information and materials in order to know what it is we're going to expect. So with that being said, again, we're developing that process. We're looking at any outreach and beneficiary case manager and provider trainings that we need to develop. And so we're working in partnership with Michigan State University, Wayne State University, MyDDI, and TBD Solutions, along with our own internal staff, to develop those training materials and make sure that those are available to all those parties that would be impacted by this implementation process. The timeline is right now determined by a consultation we will have with CMS, our Centers for Medicaid and Medicare Services, related to the impact of our current procurement process. So what that means is we, as you might know, we have began or initiated a procurement of our PIHP contracts, and that procurement process will result in a new contract procured for our PIHP system in fiscal year 27 or October of 2026, which is when that will take effect. So once those new PIHP contracts are signed, we believe that would be the time for us to implement the majority of this work, so that we are working with the partners that will be approved to continue those services and monitor those services going forward. What does that mean, though, in the meantime, is that we're trying to get that training stood up. So that training, of course, for those involved and for all the new potential organizations or entities that might be involved post-procurement, that we have those ready to go, so that we, again, are working with the same playbook, so to speak, right? Everybody's working from the same materials, and we understand what the expectations are going forward. So again, stay tuned as we will continue to update this group and others as we move this work forward. Next slide, please. And I just want to make sure I'm checking in with those who might be putting things in the chat. And again, if you have anything you want to ask, feel free to raise your hand or put it in the chat, and we will get to it as we can throughout the presentation or at the end of each part of our segments. So feel free to ask any questions you have related to these updates. So the next thing I want to talk about is that we have had a recent settlement signed by a federal judge in January, and we're calling that settlement agreement the WASCL settlement agreement, related to self-determination and making sure that we are assuring both in policy and contract language and in how we are implementing the settlement requirements, that we have we will be releasing policies that will be impacting several areas of our Medicaid provider manual. So we wanted to cover those a bit more and make sure that you were tracking on the fact that very soon now we will be releasing for public comment the first of 2 policy changes that are as a result of this settlement agreement. So the things that you'll be looking for in the policy that will come out for public comment this month are things around clarifying what we want to see in determining medical necessity. You're going to see some specified determination criteria that is specific to and unique to the person served. we're going to have an expectation or clarification around clinical information that would be included in the medical necessity assessment, including assessments and input from the person served. We are limiting, more specifically, the prepaid inpatient health plans or PIHP's decision-making authority related to changing anything that might be in the person-centered plan or individual plan of service. We're talking about what the role is for the PIHP in those self-directed arrangements, including requirements for how you would be responding as a PIHP to any budget reductions or any denials of self-determined arrangements going forward. So those are all a part of that first round of policy changes that you will be seeing through public comment coming this month. Next slide, please. In addition to what I've talked about related to some broader changes under medical necessity and decision-making by the PIHP, we're also going to better define the administrative law judge, or what we call the ALJ authority, in reviewing denials or reductions of self-determined budgets and arrangements, and what we call choice voucher budget hearings. So those are those hearings that would first start at the local level if an appeal is wanted. And then once you have exhausted your local appeal rights, you are able to move to the state appeal process, which is where the ALJ authority comes into play. And for the first time, we will, through this settlement agreement, be amending policy to allow for the ALJ to have authority over reviewing self-determined arrangements and decisions made around those arrangements. We will also be looking at, again, as I mentioned, not only changes to those arrangements, but any terminations for those arrangements to be offered the opportunity to have it heard through an ALJ decision-making process. We have better defined community living supports and what they include and don't include as far as costs that can be reported under CLS services. So it's not just the service itself, but it's also to consider that there are additional costs when you are in a self-determined arrangement and you're considering what your budget might need to look like. You're going to want to think about those costs that are both direct and indirect. And so we're making sure that that's included. We're talking again about better defining fiscal management services or FMS responsibilities in a self-determined arrangement. And we're defining specific person-centered planning requirements related to those arrangements. And what I mean by that is as people may come to have their discussions related to what they want to see in their plan, that they might have conversations that need to be reflected in that plan, even though there may not be a goal or an outcome that as a result. For example, you might say, I'd like to consider having this as part of my plan. And what we're saying is in these new policies, we're asking and expecting that conversation is documented so that we understand that you may be asking for something and it may never show up in the treatment plan, but it is part of a conversation that you're having as you have your person-centered planning discussions. And we would like a more reflection of those conversations in writing or documented as part of that plan process. So I'm going to stop real quickly here and take a look at anything in the chat. I'm going to scroll up a bit. So this one, I think, might be back to our conflict-free part of the presentation. Claire asked, is providing both case management and provision of HCBS services by the same entity considered a conflict? And yes, that is a conflict that will be addressed through the process that we will have to assure that if you are receiving case management services from a one entity, that they cannot also be the provider of your services, because that would be considered a conflict. Is it Janine? Says, I have a question, but it's easier to, if I'm off mute. What can we do to answer Janine's question?
If you scroll down just a little bit further, you see she's typed out her question.
Okay,
And
perfect, thank you.
it says, so what I hear you're saying is that it's just going to be based on the person's need. And like a medical model is the understanding of how it is currently.
So I'm assuming we're talking about how we are changing sort of that medical necessity potentially criteria. And that has always been fundamentally at in policy, that any decisions that are made related to services and supports have that sort of foundational medical necessity criteria met. However, as a part of that, you must include the voice of the person served, and those that might be naturally supporting them are part of their support network. So we want to highlight that a bit more in the policy changes that we're making. And so again, as you review those policy changes when they come out in public comment, I hope that's what you're seeing in those changes.
There's another related question.
Okay.
Will the medical necessity language specify how this is interpreted related to skill building and employment services?
It's not specific to a service. In the changes we've made, there might be some you might find uniquely changing because in that service piece, because of the settlement agreement is focused on the HAB support waiver, CLS, and overnight health and safety. So that was the focus of the settlement agreement. However, some of the policy changes we've made have a broader impact. And so, yes, we would expect that when you see those changes in the medical necessity portion of the policy, it would impact all services, right? It would not be unique to one or two. So I'm moving down, then I'm looking at Beth has a question related to WASCL. Is it still up to the local CMHs or PHPs to determine who gets to apply for the HAB waiver? So although it is not specific to the WASCL settlement, and Lyndia Deromedi is here today as our federal compliance manager and may be able to talk to you or anyone else related to specifically how we look at eligibility for HAB support waiver. However, there is no reference to eligibility and or who is determining that eligibility in our WASCL settlement policy changes. And so I'll let Lyndia kind of address that one. Either now, Lyndia, you can jump in and address, or we can wait and have you talk about that in your section. Any thoughts on that?
Sorry, I'm so used to Teams, I could not find the unmute button. I was looking in the right corner. So our eligibility, in terms of who gets to apply for the HAB waiver and the HAB waiver eligibility, the HAB waiver eligibility, as it's written in the application, is that the individual has the service needs up for institutional level of care, and without these community-based services would require institutional level of care. That does get determined at the PIHP and the CMHSP level, but we do have requirements. So they have to have a habilitative service need, and that they also, I just lost my train of thought. But more so, they just need a habilitative service need. And again, they must meet that criteria for institutional level of care if not receiving those community-based services. Each PIHP is allocated slots, and that's based on their Medicaid members per month. But we have been working with the PIHPs if they have an additional need, that we will look at other regions who may not be utilizing other slots and kind of moving those. The department also has slots available for PIHPs to borrow. So you know, anyone can really, if they think that they meet that level of care for the HAB waiver, they can apply. If they're already approved and receive services through the CMHSP, they can request an application and express their interest in the HAB waiver, and they will go through and complete the application process. What we do look for is we look for the plan of service. We look for any supporting clinical documentation. There is what we call a performance of major life activities document that needs to be completed. And also there would be some form of assessment that's done. We are moving into the HUDOS assessment for individuals with intellectual and developmental disabilities, which I will speak about. So that can also be used, but biopsychosocials are acceptable at this time. If the SIS assessment is still active, that would be, you could use that too.
Thank you, Lyndia. So again, feel free to ask additional questions of Lyndia as we move to her section of the update related to the work she's doing in federal compliance. Again, thank you for all the questions. It helps us to know what's on your mind as we're presenting on this new information. And I'm hopeful that it will reflect in your public comment as you see these policies come out. So I see another question. What do you do if you have a conflict, and who do you go to? So if you are a person served by a CMH for services, behavioral health services, you want to make sure you're bringing any concerns that you might have to your case manager. And if you feel that there is a conflict with that person, your case manager, for example, you should have access to, in every CMH, a customer service person who you can reach out to and listen, and you can talk to related to your concerns. And the conflict I'm assuming you might be thinking about is you want somebody else to be your provider, either case management provider or your service provider. And you want to make sure that you have choice. And that is, again, very important that we make sure that choice is made available to you. So again, that would be who I would reach out, is within your CMH. You have either directly through your case management organization, an opportunity to talk about what you feel is conflictual. And again, if you feel like you can't do that, there is always the customer service and recipient rights sections or departments within your CMHs that you should be able to go to. Medical necessity, Barbara's indicating, needs to be better defined for community-based services because it doesn't really make sense for those types of services. They should also have to explain their denial of services more clearly. Right now, it's not explained at all. So again, I appreciate the comment, and I hope that, again, what you're going to see in our policy changes might get at some of the concerns raised here. Elise says, how does this help and support the new K-12 literacy dyslexia laws? Again, not applicable to the content of what we're presenting on today, but would be happy to discuss further what your concerns are related to these new literacy laws, or maybe there might be somebody else within the webinar series that can help answer that question for you. Janine, I hope it's Janine. I can't see the full name, but it says, I'm in a wheelchair, used, and I can't do anything by myself, and I only have 6 hours a day. So I'm assuming, again, you're really trying to help us understand what your support needs are and how important those are, that they are provided to you. It sounds like 6 hours a day is something that you would like to maybe see changed. Again, I hope that you're able to work with your case management organization and your CMH to address any concerns that you have related to the supports you need every day. Annette, what if they are not given you choice? So if you're not giving choice, and when we say choice, it means that once services have been determined for you. Any supports or services that you need, you should have the option to choose among providers who can provide, who are first trained and approved to provide those services to you. And if you're not satisfied with who is providing those services to you, that you have a choice on another option. So again, I'm hopeful that I'm getting to the answer to your questions, but again, continue to talk with us as you have further questions. Excuse me, just a second. Okay. Next question, will choice in case management agencies be enforced? And that's from Claire, and yes, absolutely. We will have an expectation of oversight and monitoring of making sure that people are given choice, both by the PIHP and by the state. So as we are talking through the implementation of this conflict-free requirement, we're going to start to integrate our expectations in our audits of those PIHPs and CMHs to assure that they are complying. Barbara indicates one overall problem is that the system is not explained to customer and families at all. So the support coordinators don't tell you about all of the rules and how they work, that you have the option to try for the HAB waiver, how to manage a budget, how to do a PCP, etc. Is there a provision that the CMHs have to provide training and explanation in those areas for clients and our consumers? Our county discourages independent facilitators, so they now have to be provided if we feel the conflict of interest for CMH provided supports coordinators is too high. So I think absolutely, Barbara, I can appreciate that you are recognizing within the system that perhaps the first thing we want to do is make sure through our outreach efforts and our training efforts that everyone understands what the expectations are for these conflict-free access and planning rules, both in how you experience those rules as a person served or a family member, as well as the support coordinators and those providers of those services, that they, again, they understand how what the expectation is related to implementing the compliance around the rule and assuring that people have, again, an understanding of what that expectation is as well. So what we're hoping to do is through our work with Wayne State MyDDI, and they are working with us right now to develop a curriculum that will be for people served and their families to understand the expectations of the rule, the tenets and values of the rule, and how we would offer you tools in coming to the CMH, understanding what your role is in that process going forward. We're also monitoring, by the way, the use of independent facilitators. We've had more opportunity in the last year or so, actually 2 or 3 years, to develop a way to monitor how many times independent facilitation is used by way of billing codes. So we hope to have more information about maybe areas of the state where it's not being used, and making sure that we are shoring that information up going forward. Another question from Janine. So is this going to change or chance I have HAB waiver, I'm self-D? So if you are on the HAB support waiver and you are in a self-directed arrangement, or you are directing your own services, it should not change those services for you, but it will offer you more opportunity to, when the budget is being developed, to really negotiate, right, what you need in order to recruit your staff, make sure that they have what they need to continue to support you going forward. And if, again, there's a change in your budget or a change in your arrangement, either a reduction or a termination, that you have a little bit you have more in the way of rights and appeal rights, particularly to have that reviewed by a third party. Eileen asks, says there's such a vast difference in the extent of knowledge support coordinators have. When supporting a client, I had a support coordinator who said the HAB waiver was only for retrofitting of home if there were any physical barriers to the person. Is there anything being done to increase knowledge of support coordinators and to assure they are aware of programs, services, waivers, etc., especially when the client has more challenges? It seems as support coordinators are unaware of all the needs and possible services to assist clients. And yes, we are actually developing a support coordinator curriculum. We're going to talk about it in the form of person-centered planning, conflict-free. We are also hoping to add a chapter on transition services so that when you are moving from one level of care, for example, a hospital level of care or any kind of crisis stabilization or anything that might be considered a higher level of care into a community setting, that case managers know and have the tools ready to support you. So we're engaging with some folks that are able to provide us some content related to that. And we're going to start to infuse that in a curriculum that will not only be focused to support coordinators, but to providers of service. And again, as I mentioned, to families and individuals served. So it'll come from various sources, like the home and community-based services rule will be a part of it. Conflict-free will be a part of it. And then we're going to add some person-centered planning components as well. And I'd love to, again, check back in with all of you as we move that work forward to assure that we're going down the right path, right? That we're covering the areas that are important to you. So I'm glad to hear that you have some interest in that, and we'd love to circle back with anyone interested in perhaps providing the department input on that. Again, I'm just trying to catch up on where we are with questions. Again, appreciate the questions. Okay. Is the webinar being recorded for later review? Yes, it is recorded, so you should be able to get access to that after we are done. Oh, I see that that's been answered. Thank you. Barbara asked, someone told me that there was a question of whether the consumer is actually the employer for self-direction at the last or latest self-determination conference, and some confusion over that answer. Has that been resolved and clarified? And if so, what is correct? So depending on the type of arrangement you would like, yes, you can be the employer for your self-direction arrangement. Sometimes people don't want to be, right? They want to have someone else assist them to be that employer, and that's also acceptable. So I hope that answered the question. Janine, I have a miracle device, and they say that I only need 6 hours because of that, I'm assuming. I have natural supports. It's just going to change. Okay. Okay. Eileen, I went through the independent facilitation training. I had one CMH insist I needed an NPI number, and I don't have one, and then they never paid me for the work I invoiced for. Providers often make it difficult for independent facilitators to do their work. Yeah, and we had quite a bit of discussion about independent facilitation and what the requirements are for training. And we understand that you wouldn't likely have an NPI number, and that is not a requirement for an independent facilitator to have an NPI, right? You should just have a way forward with your contract with the CMH to cover your invoiced costs. So I would hope that you have a way forward to still get paid for the time and services you delivered. And we know that independent facilitators have often had some difficulty in either getting the contract started or what the expected trainings are for you. And we've made some of that pretty clear in our policy manual now and in our code chart. So we'll come back to that one and make sure that, again, we are emphasizing the importance of going back to those policies and understanding what is and isn't a requirement for those facilitators. Okay, I think I'm going to go ahead and move on, and we can continue to come back to the chat going forward. I just want to make sure we have time for Lyndia's presentation as well. So I think we've covered this slide related to some policy updates. Again, look for the policy to come out for public comment this month. Next slide, please. So this is just a quick plug for our Developmental Disabilities Practice Improvement Team, what we call DDPIT. This is a group of folks that were brought together by the department many years ago to promote, articulate, and provide leadership around and make recommendations around services and supports for people with intellectual and developmental disabilities. And again, assuring that through this DDPIT and as well as other venues that you have what you need in the way of services and supports going forward. So I wanted to make sure that you were aware that we have a DDPIT that is both membership is both from the department as well as people served and other community organizations. And why I'm bringing DDPIT up, and I'm glad you moved to the next slide, but membership is because we're recruiting. We are actively interested in having people with lived experience and or their families represented on this group. And we're hoping to develop a way forward to assure that the time you commit to being a part of this group, that you are reimbursed for your time. So we're looking for ways that we can make that happen. We want to make sure that you are a member of the developmental disabilities community, behavioral health, people with lived experience and their family members. Again, we would be asking for you to participate in various policy and service issue conversations that we might be having. You want to be able to empower and raise awareness of different initiatives that we might be involved in, resources and supports. We do have the meetings on a monthly basis. They are virtual. And we also expect that if you're interested and can commit to involvement in any subcommittee or standing committee work that we would do as it relates to those services and supports. I did include the link to the ARC Michigan webpage that allows for you to, quote, apply for being a member of DDPIT if you're interested. Next slide, please. So quickly, I wanted to introduce you to our new IDD specialist. Her name is Emil. It looks like you might pronounce it differently, but it is Emil Mansour. And some of the key projects that Emil will be working with the department on very specifically is making sure that we continue to have or hold the National Core Indicators surveys once a year, that we will ask her to take the lead on implementing the World Health Organization Disability Assessment Schedule, or the HUDAS, which, if folks are familiar with the support intensity scale when we had the SIS, this is a new assessment tool that is replacing the SIS and helping us make decisions about eligibility for services and informing those assessment and eligibility processes. She will also be facilitating the DDPIT that I just talked about and any other policy initiatives that impact the IDD population. And one of the things that I didn't mention specifically on this work and related to new initiatives is that we are starting to talk through how can we invite technology into our supports and services. So there's a group that is working on some technology first initiatives in Michigan, and we have been asked to be advisory on that group's work going forward. So that is work that is funded through the Michigan Health Endowment, and we have been asked to advise that group on their work going forward, and we're happy to do that. So Emma will be involved in that work going forward. Next slide. Last thing I think I wanted to touch on and make sure again that you are aware of is that folks have within our department, and as we've talked to all of our external stakeholders, identified that we do have a continuum gap area in serving people with developmental intellectual disabilities as they might move through a continuum of care or level of care that they might need. And I think the pandemic and COVID really brought to light, right, the areas that both in our community and in higher levels of care are needing more work in related to how we support people with intellectual and developmental disabilities. And some of the things that I noted as we were going through the pandemic, and as we have now come out the other side of COVID and the pandemic, is the fact that we have seen, and unfortunately, an uptick in the admission of people with IDD into nursing homes. We've seen our provider network, particularly our residential and specialized residential provider network, impacted by the pandemic and have not fully recovered from. We know that the direct care workforce was impacted and continues to feel the impact of those sort of restrictions during COVID and how that might have impacted services and supports, both from the people receiving them as well as for those providers providing them. So we're really trying to better understand through this IDD continuum work, what are the needs for people with intellectual and developmental disabilities that are long-term, right? Some might be short-term, some might be crisis related, but most are long-term supports and services. And we need to be able to really have a continuum that is flexible and time sensitive and responsive as people need different levels of care as they develop and they age. And we need to be ready to provide those. So we are working with both looking at national models as well as state models to inform policy and levels of care decisions that we're going to make going forward. And in that regard, we want to know and hear from you related to what you think those needs and supports should look like. So a survey will be released in the next month or two for you to provide feedback to us related to what we want to propose going forward. So I'm hopeful that you can take the time to complete that survey and get that back to us. And again, if you don't receive the survey in the next few weeks and you want to make sure you're a part of this and are able to at least contribute to participating in the survey, feel free to reach out to me. I'll pass it on to our team that is conducting the survey, and we'll make sure that they have your information in order to send it to you and make sure you're a part of that survey process. So I'm at the end, I think, of my presentation. Do I have another slide? Maybe. Okay. So I'm going to hand it off to Lyndia in a minute, but I want to make sure I've covered everything in the chat. Okay. So I see Brett, I think, might be asking questions related to the notices for public comment. Can we make sure they are drafted in plain language? Yep, good catch. And we will make sure that is the case. Barbara saying thank you. You're welcome, Barbara. Looking at the time, do you want to go back? Okay. So Eileen, I'd be interested in assisting and reviewing or providing input on training for support coordinators. Again, I'll look to Sherry and others on this team to make sure that we have the contact information for anybody that is expressing interest, and we'll be happy to circle back with those interested. Thank you. I am seeing another interest in the developmental disabilities practice improvement team. Perfect. Barbara, thank you. Jackie, I've been requesting trainings for individuals served and their caregivers. Thank you for addressing this need. You are welcome. Okay. Annette, are you up to a direct care worker in this group? Oh, I'm assuming Dee Dee Pitt. Absolutely, we'd like providers represented. So we would love to entertain having a provider, particularly a direct care worker involved. Jackie's asking, can you be in the Dee Dee Pitt and the back? And not sure if we're talking about that beneficiary advisory council. Jackie, and yes, you are absolutely, there is no reason why you can't be in both if you're interested in being in both. Are the DD Pitt meetings open to the public? They are not, Barbara, at this time open to the public. Carl is asking, 55% of us with, I think I'm gonna mess up the way this is pronounced, ankylosing spondylitis, end up with Parkinson's. I'm struggling with functional movement disorder and 14 years of physical disability. I want to help, join and help however I can. My long-term disabilities has to do with family PSDT. Yep, I've had various temporary systems, lots of experience here, it looks like. I go outside, okay. Send the survey to me. Okay, Carl will be again, hopefully we can have your information and we'll be happy to do that for you. Okay, is DD Pitt only accepting apps from families of children or can families of adults apply? Both, absolutely. Families of adults can absolutely apply. Okay, interested in support coordinator training, says Tracy. Okay, and then Annette is asking, can we have a direct care worker be involved in everything at the ARC? And how do I do that? So I think I'll let the ARC answer that question. And I think I'm all set. Thanks again for your time today and all the great questions. And as always, we appreciate being invited to your annual webinar. So I'm going to move and let Lyndia Deromedi present on federal compliance updates. Lyndia?
Yeah, so I'm going to go through this relatively quickly because we don't have much time. So my apologies for my speed talking and really going through this quickly. I think if you have any questions that we're not able to address here, or I can always get them from the ARC and we can make sure that excuse me, we respond. So let's go ahead and get started with this update. Next slide, please. As Belinda mentioned, I wanted to just kind of give you an update of where we are with the world, excuse me, the World Health Organization Disability Assessment Schedule. So you will be hearing us refer to this as HUDOS. When we do talk about that, you know that this is the assessment tool that we're speaking of. Next slide. So the HUDOS 2.0 is the assessment screening tool that we're using. So it will be used to determine eligibility for the 1915 State Plan Amendment, or you will hear that referenced as ISPA. It is also going to be a screening tool for the Habilitation Supports Waiver, or many of you know this as HSW or HAP waiver. Again, this will be used for individuals with an intellectual and a developmental disability who are 18 years or older. And it will also be used to help inform person-centered planning. Next slide, please. So this eligibility assessment tool, if any of you were at this presentation last year, I believe I provided an update of how we got to the decision as a state to use this tool. And we did have input from clinicians, individuals served, family members, advocates, and based on 4 assessment tools that we looked at, we did testing. We found that the HUDOS would serve the state of Michigan and our needs the best. So this is a 36 item tool. It evaluates 6 domains. So cognition, mobility, self-care, getting along in terms of getting along in your daily living skills, your life activities, and participation. This assessment tool, you will be happy, is much shorter than the SIS, the support intensive services assessment tool, and we found it to give us what we need, but not be too intensive or take as long to complete. Next slide. So I thought it would be helpful just to put the crosswalk in terms of what we will be looking at. So you can see the different areas, self-care, communication, learning, mobility, self-direction, capacity for independent living, and self-sufficiency. So these are these are the questions that we're looking at, that the HUDOS asks, and then how we're applying them to the different areas of our requirements as it relates to eligibility for the 1915 ISPA and being used as a screening tool for the HSW. And let me just provide a little bit of clarification of what I mean by that. So we have allowed, and I spoke to this earlier about using different assessment tools to determine potentially eligible folks for the Habilitation Supports Waiver. And so we as a state have been looking to get one assessment tool that we can use for this population. So when we say screening, what we mean is that the HUDOS will assist in identifying potentially eligible individuals for the Habilitation Supports Waiver. Next slide, please. So where we are with our timeline, and as Belinda said, we have our IDD specialist, and we've introduced her into this work, and she will eventually be taking over. We had a steering, we're going to have a HUDOS steering committee. We put out the application at the end of May. We are reviewing applicants at this time. So we anticipate, I think we have a meeting today. I think we'll be able to finalize those applicants. We'll be sending notifications to those that are chosen. We're looking at about 20 people as part of the steering committee. The steering committee will be clinicians from the CMHSP, PIHP. They will be individuals served, advocates, family members. And we're looking at starting this committee in July of 2025. So from July to spring, the steering committee is going to work on the following things, because our goal is to have full implementation of use at the beginning of fiscal year 2027. So this committee will be working with the department to define the manual. So we always have a assessment tool manual that's used to ensure that we have consistency across the state, to ensure that it's being used consistently across the state, and that people who are administering it know exactly what, how to administer it, what to do, as well as individuals served and their family members have a good understanding of this assessment tool. Why is it being used? How is it being used? They're going to also assist us with technical guidance with the development. And we also want to do testing. So it was very important for us to ensure that we get individuals who, we have individuals who are receiving services or their family members, so they can assist us with testing. They can give us their feedback. Again, when we had the work group to determine the assessment tool that would be used by the state, it was incredibly valuable to have their feedback. And so we really wanted to make sure we did not lose that aspect and that perspective. We do have some flexibility with the implementation timeline. We think that we might be able to start implementing it in fiscal year 2026. it's not a hard, fast rule that we're going to, but based on our timeline, we think we can start to do some of the implementation, at least, maybe a pilot. We are really flexible in terms of this, and we want to make sure this implementation is done effectively. But ideally in FY27, we would like that to be the assessment tool that's used. Next slide. I want to give you a couple of quick updates. So many of you may or may not be aware that we just had an amendment to our state plan amendment, and that coincided with our Habilitation Supports Waiver renewal. We wanted to make sure we were consistent. We wanted to make sure that any updates we were making to the waiver, the ISPA correlated with those updates. Next slide. You're going to see a lot of the same things that we updated, again, just for that correlation. Some of the things we updated because we heard feedback, and some of the other things we updated because CMS asked us to update those. So again, we added the HCBS assessment tool as well as the MDHHS because the 1915 ISPA provides services to both adults and children. And that's adults and children with SED or serious emotional disturbance, serious mental illness, and intellectual and developmental disability. We also updated some language with vehicle modification. That was a CMS request. Environmental modification, that was to align our language and also ensure that we were aligned with what was required by CMS. We updated family support and training language, and that was really to move the peer supports out of the 1915 ISPA, and that is now a state plan service. It's an EPSDT service. And then also we updated fiscal intermediary to fiscal management services because that's the terminology that's used at the CMS level. We also updated our housing assistance language. So we changed the criteria for staff that can provide this service. So we actually are allowing people at the direct care service level to provide those services. They just have to have an experience and background in providing assistance to people with housing. We also updated our skill building language. We kind of created two paths for that. We updated our CLS language. And we also, this was CMS's requirement, we had to create two separate services for supported employment. So there's individual supported employment, and then there's small group supported employment. Next slide. The 1915 ISPA bulletin, that should be going out for public comment within this month. We are also beginning work on another amendment, and the new amendment would including non-family training, adding a CLS per diem service, inclusion of overnight health and safety supports as a service, also as a per diem. We have some performance measures we are adding. And then we're also just one of the good things we're doing in terms of trying to reduce administrative burden is we are in the process of moving our waiver support application work into an API interface. So we have testing underway with one of our CMHSPs, and that's Lifeways. So I see I have about a minute left. I can try and race through this as fast as I can, but I'm not sure I'm going to get through everything. I probably can get through this relatively quickly because there's many of the same updates. So let's go to the next slide and let me see what I can do in a minute. We added allocation of waiver capacity language. So that was related to we made some changes in terms of slot allocation for the PIHPs. So again, that was what I talked a little bit earlier about being able to move slots if there's a wait in one area, not in another. We added freedom of choice language. This is the screening tool regarding HCBS. We also opened it up to a new eligibility group. So that is the Tax Equity Fiscal Responsible Act of 1982, TEFRA. You're going to hear that mostly referred to TEFRA. And that's a service, that's an eligibility group for children. We also had some general service specifications language. We added service plan development process language. This was all a lot of what CMS required us to add that was not in there before. Next slide, please. Again, we had to add methods for remediation and fixing individual problems in the plan of service language. We did eliminate pre-vocational services. We added vehicle modifications as a distinct services. We updated the environmental modifications, same as what the 1959 ISPA did. We also added, added eligibility coverage and service language description for overnight health and safety. So we could kind of expand that. We also updated goods and services language, and that is reflective of adding a $2,000 limit, but also removing that need for human service for goods and services to replace a human service. Oh, does this? It looks like this slide duplicated. So next slide, please. Yeah, and I see I'm over time. I'm not sure what we want to do here.
Lyndia, this is Sherry. Katie said to go ahead and take a few more minutes. She's okay. The next presenter. Thank you, Katie.
Okay, thank you, Katie. Appreciate that. So again, there was a lot of this is language CMS wanted us to add, informed choice of providers. We had to update the enhanced medical equipment and supplies language related to CMS requirements. We updated respite language to add some additional settings. We updated the family training language. Again, we changed fiscal to fiscal management, updated CLS language, and we did the separation of supported employment. Small group. Next slide, please. Just a couple of updates. We sent the CMS report in. That was finalized and sent to CMS on 5/12. We're finalizing the HSW bulletin about all of the waiver renewals and the changes. And we're working on another amendment. Same things as what the ISPA was doing. Next slide. So this is our cap from CMS. So I'm going to go through this quickly. I know this is a lot of information, but let me at least try and get through this so you all have this information. So many of you may or may not be aware, but CMS did a site review, an in-person site review with us last July. And so what I'm going to provide here is really kind of where we are with that corrective action plan. You'll hear me reference that as a cap. So CMS visited 5 of our behavioral health providers. And where we are with that is actually, I got an update from this. So all of our 5 HCBS providers have provided their cap. We did send them back some clarification on a few things. And I just spoke with our specialist in the home and community services rule. And she said that I think we are good to approve, I think the 5 that sent the clarification. Regarding our 10 PIHPs, same thing. They sent their caps in a timely manner. They've already been implementing some of those things. We sent some emails for clarification. And again, they're sending those back. And overall, I'm going to say we are seeing some really good responses. We are seeing them take sending effective corrective action plans, really taking this seriously and ensuring that they're following the requirements. Next slide. We also, on our part, we at the department also had a corrective action that we needed to do for CMS. And one of those things was updating the Medicaid provider language. So what we did is we created a behavioral health, home and community-based services chapter. And that really is very detailed in terms of all of the requirements related to HCBS. We also have updated our PIHP contract language. The last time we met with CMS was in April. They reviewed, we gave them an update of where we are. They did agree that we could extend our implementation deadline to 9/30 because we knew we were not going to meet the initial deadline, which was, I think it was April 10th or April 11th. We are also finalizing the HCBS provider training. We are very close to that. In fact, we just reviewed it the other day and are getting ready to send that back for corrections. And but our intention of that in terms of the training, we're trying to figure out the best way to implement that. We're getting some feedback from providers. Also getting feedback from our CMHSPs and PIHPs. We do believe we will provide an initial couple of trainings. It won't be required. I mean, if our providers can attend, great, but there will be other opportunities for our providers and CMHSPs to utilize the training we create and then train their staff. Next slide. Okay, I made it. I think there was something in the chat. Sorry, I saw that going through. We can go ahead and take your questions and I can send a response.
All right, thank you so much, Belinda and Lyndia.